The oxygen saturation was decreased both in volunteers and patients, but it was only significant, statistically significant in case of COPD patients, not in volunteers. So, in conclusion, the distance walked by healthy subjects is greater than COPD patients, and walking distance differs between stage 1 and stage 2 COPD patients. There is significant difference between pre- and post-test heart rate, respiratory rate in both COPD and healthy subjects, but oxygen saturation changes significantly only in COPD patients, not in healthy subjects. So from this study, it is justifiable that 6-minute walk test should be recommended as one of the standard lung function tests in staging of COPD as a parameter of the therapeutic response in COPD patient, in evaluation in pre- and post-operative state, and in overall evaluation of COPD patient. Thank you all.
Chairpersons, rapporteur, their learned audience, Assalamu alaikum. I am going to present my topics. Developed the spirometer in 1846. Measurement of the so-called dynamic lung volumes and of maximal flow rates have been used in the detection and quantification of disease affecting the respiratory system. Spirometry is the dynamic lung function test. Even now, its utility and interpretation is not fully clear to the physicians, so the test is rarely ordered. In this brief presentation, we will try to understand the utility of spirometry and its interpretation. Now, what is spirometry? Spirometry is a method of assessing the lung function by measuring the volume of air that the patient can expel from the lungs after a maximal expiration. Now, what is the utility of spirometry? By doing the spirometry, we can answer the following questions like: how badly impaired is the patient's lung function? Is air obstruction present? How severe is it? Does it respond to bronchodilators? And is treatment helping the patient? How great is the surgical risk? Is the patient dyspnea due to cardiac or pulmonary dysfunction? Does the patient with chronic cough have occult asthma? Is obesity impairing the patient's pulmonary function? Is the patient dyspnea due to weakness of the respiratory muscles? These all questions can be answered by doing spirometry. Now, why we perform spirometry? Detection of respiratory disease like obstructive and respiratory disorders and its severity can be assessed by doing spirometry. Identification of asthma triggers, progress or natural history monitoring, treatment response assessment, and preoperative assessment. Now, what are the standard spirometric indices? Important spirometric indices are FEV1, that is volume in 1 second, the volume of air expired in the first second of the blow, and FVC, forced vital capacity, the total volume of air that can be forcibly be exhaled in 1 minute, and ratio of these two, that is FEV1 and FVC ratio, the fraction of air exhaled in the first second related to the total volume exhaled. And other indices are peak expiratory flow rate, FEF 25 to 75%, and slow or relaxed vital capacity. This is particularly important in older patients in COPD. And another important indices are FEV6, a forced expired breath lasting for only 6 seconds. This often approximates the FVC, but is easier to perform in older and COPD patients. Recently, it is replacing the FVC. Now, what are the normal spirometric curve? There are graphically two spirometric curve. One is flow volume loop and another is time volume curve. These are the time volume curve, and this is the flow volume loop. In below it is inspiratory loop and upside it is expiratory loop. Now, what are predicted normal values? The predicted normal values of spirometry is depend on patient's age, sex, height and ethnic origin. Normal predicted values are collected from normal individual up to the age of 70 years. FEV1 and FVC in over 70-year-olds often falls below 0.7 and 0.65 should be taken as the lower limit. And young people, FEV1 and FVC is nearer 0.8. And interpretation of normal spirometry. After doing spirometry, we interpret it as normal and abnormal ventrally function. This abnormal ventrally function may be obstructive, restrictive or mixed pattern. In obstructive respiratory abnormality, the curve is slow rise, reduced volume expired and prolonged time to full expiration. But in restrictive disorder, the fast rise to plateau at a reduced maximum volume. And classification of ventricular abnormality by spirometry. In obstructive disorder, FEV1, both FEV1 and FVC reduce, but FEV1 is reduced more marked than FVC, so ratio of FEV1 and FVC is 4. And restrictive disorders, FVC is reduced more marked than the FEV1, so ratio is normal or increased. Now, what are the spirometric features in obstructive airway disease like asthma and COPD? At first, we look for FEV1 and FVC. If the ratio is less than 70%, it is regarded as obstructive ventilatory disorder. Then we look for FEV1 to see the severity of obstruction. If FEV1 more than 70%, it is mild obstructive ventilatory disorder, and more than 60%. 60 to 70% is moderate obstruction, more than 50% moderate to severe obstruction, and less than 50% it is severe obstructive ventilatory disorder. After confirmation of obstructive ventilatory disorder, it is next step to confirm why it is asthma or COPD. Of course, clinical information is the paramount importance to differentiate from asthma and COPD. But by doing spirometry, by bronchodilator response, we can confirmly say that it is asthma or COPD. By bronchodilator response, at first baseline spirometry is done. Then 2 puffs of salbutamol, that is short-acting beta-2 agonist is given. Again spirometry done after 20 minutes and 2 spirogram is compared. If FEV1 improvement is 12% and 200 ml from the baseline, then the response is positive, that is asthma. Reversibility test also provides the best FEV1, key to making accurate diagnosis, helps to differentiate COPD from asthma, needs to be interpreted with clinical history, test done as a planned procedure, and it is time consuming, could be done on first visit if there is